So, here we are again. You know that prostate cancer, again, I like to always to overview all the different radiopharmaceuticals that you can use. With prostate cancer, all these radiopharmaceuticals have been used in literature. Today we will talk about only the use of carbon-11 choline and fluorocholine. First, just start like this straight, why we use choline and we don't use FTG, because as you probably know, choline has a better sensitivity. This is the same patient studied with FTG here. This is a very old study, 2006, with FTG here for lung cancer and with choline for prostate cancer. Only 2 or 3 days between the two scans, and as you can see here, there is intense uptake in this lymph node from prostate cancer and absolutely negative from FTG. So that's why we use FTG. This is not all the time true. Probably you have an increased sensitivity of about 15-20% between choline and FTG. It's not that that FTG is always negative on prostate cancer, but you have an increased sensitivity of about 15-20%, reasonable. And that's why choline is positive in prostate cancer, because this is the metabolic pathway of choline, and all these three steps are increased in prostate cancer cells. There's nothing much to say about the acquisition. We have a cyclotron, so we use carbon-11 choline, and the acquisition is nothing special. Now we inject the patient under the tomograph, but you can wait something like 2, 3, 4 minutes after the injection and then start your acquisition from the pelvis. And the only difference between carbon-11 choline and fluorocholine is that in fluorocholine you may acquire early images and late images. So most of the center, they do 10 minutes early acquisition and 60 minutes, or they do dynamic scan. This is the normal biodistribution of carbon-11 choline about 5 minutes after the injection. We have almost no uptake in the brain. That is very, very important if you want to study brain tumors. Intense uptake in the salivary gland, intense uptake in the pancreas, not intense, but moderate uptake in the pancreas and the liver. And if you scan the patient properly, you don't have any radioactive urine in the bladder. And that's the difference between the carbon-11 choline and fluorocholine. As you can see here, this is carbon-11 choline acquired 3-4 minutes after the injection. This is early images of fluoro-18 choline. Even if there are early images, you already have radioactive urine in the bladder. Otherwise, in the choline, most of the activity is still in the kidney, as you can see here. That is not true for fluorocholine. Just a quick advice, it's not always true. You can have also carbon-11 choline that even if you scan the patient properly after 3 or 4 minutes, maybe this patient produces radioactive urine. So it's not uncommon that you have also radioactive urine with carbon-11 choline. But just a small tip, do not ask the patient to empty the bladder before the scan, or the opposite. Just ask him to drink a couple of glasses of water, and just do not ask him to empty the bladder, because it's better to have filled up the bladder with non-radioactive urine instead of a small bladder with some radioactive. So it's better to do not ask the patient to empty the bladder before the scan. At least that's what we do. So this is one of the frequently asked questions: what is better, fluorocholine or carbon-11 choline? We have a cyclotron. So in our opinion, there's no comparison. We produce by ourselves carbon-11 choline. It's very cheap, very reliable, only maybe twice a year you have something wrong with production. And so the advantages of carbon-11 choline are that the urinary excretion, you don't have urinary excretion, better dosimetry. possible, but a better labeling. It's very easy. It's not very easy, but it's easier to label carbon-11 choline instead of fluorocholine. The cost is much lower. And also, very recently, a couple of months ago, there's been FDA approved only carbon-11 choline, not fluorocholine. The main important advantage of fluorocholine is the half-life. That is not only true because you can buy it or they can sell it, but also because you can have delayed images. We used carbon-11 choline since 2003, since 2003, so almost 10 years. And many times I would be happy to have delayed images in carbon-11, but that's the only main limitation. Once you scan the patient from the pelvis until the scalp, 15 minutes, 16 minutes, 20 minutes are passed, that is one more half-life. So it's almost, we did try sometimes, but it's almost impossible to do reliable delayed images. So the main advantage of fluorocholine is not because it's delivery, it's possible to deliver or to buy, but it's because you can have delayed images, and this may help you pretty much sometimes. So let's go to the three main application of carbon-11 choline in prostate cancer. We can divide in three chapters: diagnosis, staging, and restaging. The size is in order of importance. And why there is could be useful to have information for carbon-11 choline to diagnose intraprostatic cancer for two reasons. Because in some patients with large prostates or with weird location of the tumor, you may do more than two guided biopsy before you detect the cancer. And so this comes in a loss of time and increased morbidity. And the time between one transtrectal ultrasound guided biopsy and another, it's at least 3 or 4 months. So you have to wait 3 or 4 months, and then the patient has his PSA increasing, and then you have to repeat it. And the second reason could be that it could guide the non-invasive treatment, such new treatments like brachytherapy, IMRT in localized prostate cancer, T1 or T2. Despite this nice introduction, I think, in my opinion, and in our experience, I think at the time there's no indication to use this carbon-11 choline or fluorocholine to detect intraprostatic cancer. I don't have the time to go into details, but there is a large mass of data against or for the use of this tracer. However, this could be a potential application of the new hybrid targeted tomograph of PET MRI. In our institution now, we only perform this kind of indication. We only agree to do PET scan in this kind of indication only in patients with very high risk of prostate cancer after at least 2 transrectal ultrasound biopsy negative. And sometimes we have found, I remember 3 or 4 cases, no more, where the cancer was located in the apex or in the anterior part. Because you know that the biopsy are performed in the posterior part of the prostate. But if the cancer in 1% of the patients is located in the apex or in the anterior part, maybe you are lucky and you can find the cancer. And at the moment in our department, we don't use carbon-11 choline to guide localized therapy. And I think there's no indication, but some other centers do. Let's go to staging, another chapter. Again, the rationale for the use of carbon-11 choline. Prostate cancer is surgical. In most of the cases, it's a surgical disease. So why we want to stage the patient before? So the surgeon goes there, take the prostate, take the lymph nodes, and that's it. It's not like that, because as you probably know, the presence of N1 lesions in prostate cancer is relatively low, even in very high risk of metastasis according to PSA, Gleason, and age mostly. the maximum percent you can have is 25-30%. So 70% of the patient that underwent pelvic lymph node extraction resulted to be negative, or 70% of the lymph nodes that you remove, also in high-risk patients, are negative. But the morbidity to the patient is absolutely related to the number of lymph nodes that they remove. So they are not happy to remove 25 lymph nodes if all the 25 are negative. And third reason is because we almost do not have anything to stage the patient. CT is useless, maybe MRI and mammograms, they have good sensitivity but very bad specificity. And moreover, they don't show you where the lymph node is. And what's the role of PET in this context? We have good news and bad news. The good news is that specificity is relatively high, almost 90% specificity, but the sensitivity, as expected, is relatively low. We have a 40% sensitivity on a lymph node basis, only 40%, just remember, and 60% sensitivity on a patient basis. And this has been confirmed by the two largest studies published so far, and also confirmed by another very well conducted study from a Danish group in 210 patients with intermediate or high risk for N1 lesions. They confirmed that on a patient basis they have a sensitivity of 70%, but on a lymph node basis a sensitivity of 50%. But the good news is that the specificity is 87 and 94%. So what does it mean? That when we see a lymph node, it's probably positive. And this is again nice application, a nice field of application for PET MRI that's been compared. The two methods have been compared. In this study, only in 27 patients, but seems that PET has a slightly better accuracy, but again, this is another potential application for a new hybrid tomograph PET MRI. How can we help surgeons this way? This is a very high-risk patient, PSA 19, T3A, Gleason 8. Okay, so we perform the PET and we detect these two small lymph nodes in the retroperitoneal area. So in this case, according to the high specificity of the method, the surgeon removed those lymph nodes that resulted to be positive. These are not routinely removed by surgeons. They just remove iliac lymph nodes and not all the iliac lymph nodes. This is another weird location of lymph node. This is a lymph node in the presacral area. Also, this lymph node is not routinely removed by surgeon, and according to our indication that it has been removed. But also remember that in a very high-risk patient like this, PSA 28, Gleason 8, T3A, you can have also bone lesions since the beginning, and this changed dramatically the approach clinician should have. So this patient was treated only with radiation therapy and androgen deprivation therapy instead of surgery. This is a small percent, but about 3-4% of the patients with high risk also already have bone metastasis. And I don't know if it's possible to see, but again, very small lesions here without any structural damage on CT. This means that there are new lesions probably. So, in conclusion of this chapter, I think that a staging Choline PET CT could be suggested in patients with high risk for N1 or M1 according to T, Gleason and PSA, so according to nomograms. But remember, just please remember that the sensitivity of the method is low, so a negative choline does not exclude the presence of metastasis. So, but we can use the good specificity of the method. How? we can, as you have seen before, we can guide the pelvic lymph node dissection, or we can guide radiation therapy to the foci of positive PET choline scan, or on the other hand, and this is something that the surgeons like pretty much, when there are complicated patients with high surgical risk, the fact that we detect only one single lymph node, they do not treat the patient with surgery, but they treat the patient with less invasive therapies. And again, remember that this probably could be a very interesting field for PET MRI. And now, finally, let's come to the last chapter. Just 1 second. That, in my opinion, is the most interesting chapter. Is the biochemical relapse after radical prostatectomy or radiation therapy. You know that monitoring PSA is the best way to follow patients after treatment. And we call biochemical relapse when PSA after radical prostatectomy increase over a value of 0.2 nanogram milliliters. The problem here is that there is a very low sensitivity of whole body imaging, conventional imaging, such as bone scan, CT, and MRI, and in particular, this is very low when the PSA is low. So the majority of the patients are negative at conventional imaging, so that the site of recurrence is not detected. And what does it mean? That the patients are treated blindly, either with androgen deprivation therapy or radiation therapy in the prostatic fossa, with or without evidence of disease. So mostly they do not restage the patients. They just treat in prostatic fossa and give androgen deprivation therapy. So it could be very interesting otherwise to know if the recurrence is only due to the local recurrence, and systemic relapse, or systemic relapse only, or in some patients PSA only relapse. We never know from where this PSA comes from. Regarding local relapse, this is a parenthesis. Regarding local relapse, I think that MRI with spectroscopy probably is slightly better than PET. However, in literature, probably MRI and PET may provide complementary information. And I don't want to bother you, but again, this is a potential application, very interesting and potential application for PET MRI. And as I told you before, I think in December 2012, FDA approves the use of carbon-11 choline for PET in prostate cancer, but I underlined some sentences that I, with all the respect, don't like. They only approved for biochemical relapse, but just look at this, may help to detect localization of prostate cancer in patients whose blood tests suggest recurrence, so it means with PSA lapse, when other imaging tests are negative. And again, it's indicated for PET imaging, suspected prostate cancer, and non-informative bone scintigraphy, CT, or MRI imaging. But on the other hand, we have the European guidelines. What do they say? They say that you should not perform any imaging method, since they are very low sensitivity, if the PSA is lower than 20 nanogram milliliters. 20 nanogram milliliters, if you're not expert in prostate cancer, it means that almost 80% you have bone lesions of the time. So they say, okay, since CT, MRI, and bone scan are very low sensitivity, we don't suggest any imaging method if the PSA is lower than 20. But this is in contrast with what FDA says. They say, first you have to do CT, bone scan, and MRI, and then maybe you can do PET scan. But they say, okay, you don't have to do PET, bone scan, CT, or MRI because they are too low sensitivity. And why they say that? They are right. I think the Europeans are right, because there are a mess of data, and I always show this very well conducted study from relatively old, 2008. They studied 300 patients with bone scan, CT, or MRI, The mean value of the PSA of this population was 9 nanogram milliliters, so relatively high, and all these three investigations, they've been able to detect only 11% of the positive patients. Not only, if you look at the mean PSA values of the positive patient, they had the PSA of 23. And the mean PSA value of the negative patient, they had the PSA mean value here of 6. So it's already a very good biochemical relapse, already not early stage. We are in late stage biochemical relapse. This is what PET can do. It's already established that PET can detect the site of recurrence much better than conventional imaging, and that there is a strict correlation. These are only 3 of the many papers published so far. There is a strict correlation between the PSA value and the detection rate of PET that increases as the PSA value increases. That's, of course, it makes sense, but just keep in mind that Choline PET may identify the site of recurrence earlier with better accuracy than conventional imaging, and moreover in a single step. However, I think that we don't have to stop here, since despite the fact that we are better than conventional imaging, we still have a large amount of false negative patients. So I think that the aim of PET should be to increase sensitivity. Why? Because we may have a clinical impact only if we detect the site of recurrence early after biochemical recurrence. If we detect the site of relapse when PSA is 30, you should not use PET. First, go to bone scan. If bone scan is negative, then you can do PET. But first, lower cost and better sensitivity with bone scan. So that's why this is our study published in JNM. So it's true that with PSA lower than 2 nanogram milliliters, we have a low sensitivity, but we potentially have a much higher clinical impact. And it's true that with PSA higher than 5, we may have a high sensitivity, but we potentially have a very low clinical impact. And since I want to do scans when I have clinical impact, I think that it's better to have a higher percent of false negative, but a better clinical impact. And this is not, we don't have to be genius to understand that, as you can see here, we show that there is a strict correlation between the PSA value and the fact that the patient has multiple lesions. If you have a PSA higher than 5, as you can see here, the patient with multiple lesions are much more than the patient with single or 2 lesions. So how can we increase the detection rate in patients with low PSA? The most important factor is the PSA kinetics. So how fast the PSA increase. There are 2 values, the PSA doubling time and PSA velocity. All the other factors, so time to relapse, TNM stage at the beginning, age and Gleason score, apparently they do not have any impact on PET detection rate. So we demonstrated 4 years ago in JNM about this population on 190 patients that there is a strict correlation as for PSA between the PSA doubling time, that means how fast the PSA increase, and PSA velocity, how fast PSA increase in 1 year. There is a strict correlation as for PSA. And this data has been later on confirmed by many other studies. This is a study a group of Milan. And this is particularly interesting when PSA is low. We only selected and published our data in a European journal in 2010, only selected patients with PSA lower than 1.5, so very early relapse in this case, and only according to the PSA doubling time value. This comes from a rock curve. As you can see here, if the PSA doubling time is slow, we have only 3% detection rate, but if the PSA doubling time is fast, we have 58% detection rate. And this is also true in, these are personal data, have been submitted a few weeks ago, and this is also true in patients with a very early clinical relapse, PSA lower than 0.5, as you can see here. And this may provide you with very interesting images. As you can see here, PSA 0.94, but PSA 2 months, and very intense uptake, again, without any alteration on CT. Intense uptake in this lymph node, a small lymph node, PSA 0.8, but PSA doubling time 2 months. Intense uptake again in this very small lymph node, pararectal, the PSA 0.9, PSA doubling time 3 months, local relapse. So I think that the characteristic of an ideal patient who should benefit the most from a Choline PET as a first procedure in case of biochemical relapse are low PSA value, cutoff maybe 2, 3, 4, fast kinetic, 6-8 months PSA doubling time, patient with local relapse already scheduled for radiation therapy to exclude the presence of distant metastasis, and then young age and long life expectancy. Do you have how many minutes do you have more? 1 minute? Okay, so we can skip this one. I just want to go. Okay, just a few seconds about the clinical application of PET choline. I think there are two important clinical applications: PET-guided radiation therapy and PET-guided pelvic lymph node salvage, pelvic lymph node dissection. There are many papers that already published about the use of PET to guide radiation treatment with good results. As you can see here, 50% disease-free survival without any therapy 2 years after the end of radiation. And this is our case. You see before, we treat the patient in this lymph node here, and 1.5 years later, the patient is without any evidence of disease. Here, complete response, and the PSA dropped down to 0.1. Again, another patient like this, positive lymph nodes, treated, complete response 1 year later. And this is also true for pelvic lymph node dissection. As you can see here, 55% after 1 year after the remove of pelvic lymph nodes positive at PET. This is another case of our that has been removed. This lymph node has been removed by surgeons, and the patient is free from disease 1 year after surgery. The clinical impact is about 31% major impact in this recently published study. And just the conclusion, so Choline PET CT detection rate is strictly linked to PSA levels at the time of PET scan. Choline PET CT is useful in the detection of small lymph node and initial bone metastasis. The detection rate is relatively low, but is much higher than the one in conventional imaging. Fast PSA kinetic is the most important predictive factor for a positive PET, in particular in patients with low PSA values. And then PET-guided therapies, such as radiation therapy or extended pelvic lymph node dissection, may increase the disease-free survival in 50% of the treated patients. Thank you again for your kind attention.